Frequently in our practice, couples will reach the point of their evaluation and treatment recommendations where we discover or recognize that in vitro fertilization will offer them the best chance to have a successful pregnancy and live birth. In vitro fertilization is a complicated, high-tech process, but we work very hard to be supportive and provide education along the way to make the process less stressful for couples as they go through it. So the IVF process, again, starts with the evaluation of the female partner, testing the uterus, fallopian tubes, ovaries, and getting some blood work, as well as evaluating the male partner with a semen analysis and understanding all the factors involved in the process. I then make a plan, a treatment plan, a dosing schedule, and the nurses meet with the patient and go over a detailed calendar, instruct the patients on how to do their injections and instructions on when they will need to be seen for visits. Typically, women do subcutaneous injections for 12 to 15 days. They are seen every 2 to 3 days for transvaginal ultrasound and blood work to evaluate the growth of the follicles in the ovary. We are trying to get a good number of eggs, but not too many, which is why the monitoring is important. Once a good number of follicles reach the proper size, where we would expect a good number of mature eggs, the patient is instructed to do what's called a trigger shot. It's an injection. 36 hours later, an egg retrieval is performed in the Brighton office. The patient has an IV in her arm. She has IV sedation, so it's very comfortable. The vaginal probe is inserted into the vagina. The needle goes through the vaginal wall, into the ovary, into the follicles, and the eggs are aspirated or removed from the body. They're put into a petri dish where our embryologist looks at them. We also have a sperm sample that same day. 1 sperm is injected into each egg for intracytoplasmic sperm injection, or ICSI. That results in fertilization in healthy eggs, and we look for fertilization. This is a diagram that shows actual photographs of an oocyte under the microscope. This is what an egg looks like after it is fertilized. We see 2 pronuclei, one from the sperm and one from the egg. Those pronuclei fuse and a new embryo is formed. We let the embryos grow in culture over 5 to 6 days until they reach the blastocyst stage. A blastocyst is a fully mature embryo. We have the inner cell mass, which will become the baby, and the trophectoderm, which will become the placenta. If the couple is planning to undergo pre-implantation genetic testing, the embryologist does a biopsy of 5 or 6 cells from the trophectoderm. The embryo is then rapidly frozen or vitrified, and the biopsy tissue is sent off to a genetics lab for genetic testing. In this process, the woman is then allowed to recover from the ovarian stimulation and the egg retrieval process. About 2 weeks later, she expects her period. We then start preparing the uterus for a frozen embryo transfer. In 2018, we typically recommend what we call an elective single embryo transfer, especially if we have known chromosomally normal embryos after pre-implantation genetic testing. This results 99% of the time in a singleton pregnancy. There is a 1% risk of identical twins. A singleton pregnancy is always safest for the mother during pregnancy and also for the babies as they gestate. The risk of preterm delivery and complications are significantly lower, which is why we do recommend the elective single embryo transfer for most patients. There are some exceptions in where we may transfer 2 embryos, but this would be the minority of cases.